All right, so this is my signature assignment. I chose the insulin overdose case study here. The case involves you, which is a senior anesthesia resident. You've been working really long hours, from 6:30 a.m. the day before. Now it's 3 a.m. when the case starts. So 27 and a half hours straight. You receive a phone call after you just got out of a long surgery about a sick patient, Mr. H. He's a 78-year-old male who came to the cardiac ICU the night prior for active MI, and he has symptoms leading the surgical staff to believe that he has ischemic bowel. And although his vital signs are stable right now, his kidney function is declining. So at that time, you notify the attending of the high risk procedure that would be warranted, which is a surgical exploration surgery, and your team prepares. You discuss the situation, possibilities that you might encounter with the attending and your other colleagues, and then you guys start the surgery. Once you guys have the surgery underway, you confirm the diagnosis. However, he is losing blood. You guys have to do a transfusion. At that time, there's some labs that are drawn, and there's some alarming labs. His creatinine is high, and he has high potassium. This alerts you to his poor kidney function, declining even more. And at this time, Mr. H is going to need an intervention for his high potassium because he's not going to be able to take care of this with his body is not going to be able to take care of this himself. The attending tells you, you guys got to do the 10 units of insulin on top of the other treatments you guys are already getting. At this time, you draw up 10 cc's or milliliters of insulin and you inject it all. When you do this, you're injecting 100 times the dose. So 1,000 units of insulin at this time. So what went wrong with the case? I mean, a few things went wrong. Number one, you're fatigued. I mean, you've been on call for over 24 hours. You just got out of a complicated surgery and you're going into another high risk surgery right here that would have been high risk whether or not you had all the rest that you needed. Communication, maybe you needed to communicate that to your attending. Maybe your attending could have communicated better to you, um, just some information about the insulin because you're going to have to dilute that insulin. It's in the sub-Q form where it's 100 units per milliliter. So he could have maybe mentioned that to you. Although everyone knows it, he knows that, everyone also is fatigued at this point, and it's his responsibility to make sure that it's a safe environment. Maybe if you had some questions on the insulin, you shouldn't be afraid, to be able to ask your attending or anyone in the room, you know, is this right, or be able to confirm your thoughts on the insulin. In addition to that, you should be able to maybe tell your attending that you're fatigued at this point. Maybe you're not the best person to be going into this surgery. Resolution roles. I mean, the resolution for the patient and for you, you're gonna have to admit the wrongdoing that went on and take responsibility for the error that you had. The patient then's gonna need close monitoring by the nurse. Um, you, the attending, you guys are gonna have to speak with the family. Um, it's the attending's job to keep the area safe. He's going to be in charge of any disciplinary action too, if that's something that's going to need to happen. I also looked up an article on vulnerabilities in the surgical environment. It came out in March of 2016, and it said about 1 in 20 perioperative medication administrations and half of all surgical procedures result in a medication error and or reverse drug event. It's higher than reported in many studies, because the study was using, excuse me, self-reported errors. In the study that they used, they also were using barcode-assisted syringe labeling system that scans the drug container's print label and provides audio and visual feedback regarding the drug and concentration. Um, Out of all the medication errors, 80% of the adverse drug events were preventable, and more than one third led to actual patient harm. The remaining two-thirds had the potential to cause harm, but they didn't. So, I mean, and so, excuse me. So, a lot of the error rates are associated with incorrect labeling, wrong doses, omitted doses, wrong medications. Least frequent errors were related to boluses of medication, remaining in tubing, and wrong timing of medications. So, I mean, in this case, it was a wrong dose, not really an incorrect labeling, but um, a wrong dose and failure to realize that it was the wrong dose. In addition, the article talks about establishing an environment that promotes reporting, learning, um, and respect and cooperation and teamwork and safety, which is something that would be, the attending's responsibility in this case because that's who's highest up, and that kind of culture really needs to be there so that you can feel safe to voice your concerns. Like I said, either that you were too fatigued, maybe to participate um, in this surgery, maybe observe this surgery. You just got out of a long surgery, or otherwise, or if you had questions about the actual insulin, no question is a stupid question. It's better to be safe for the patient. Solution and barriers. Um, like I was just mentioning, all members of the team need to feel comfortable that they can communicate their concerns. Like I said, this includes questions on drug administration or otherwise. On the medication preparation and packaging, a lot of surgical medications, as the case study mentioned, are prepared um, in vials, pre-dosed, they're color coordinated, things like that. The article that I was talking about from 2016 talked about medications being barcoded, and then scanned to identify them before preparing or administering them. Um, in addition, it also talks about um, putting other kinds of audio and visual fail safes, if you will, in place to prevent some of the errors that can happen. Um, and just better communication. Maybe this maybe as the surgical resident, you need to limit your hours in surgery. Yes, you're on call for the 24 hours. Now they've started to limit the number of hours as the case study brought out that residents can work, but maybe you really need to limit the hours in a row that you can be in a surgery. Um, Barriers to all of these solutions, maybe cost effectiveness, time, fear. Maybe, like I said, maybe the resident was too scared in the environment they were in to be able to feel comfortable to mention their concerns. Maybe the attending felt too rude to say, to give a reminder of, hey, this is how you need to dilute this insulin, or how do you prepare the insulin, or how do you plan to do that. That would have clarified it and also prevented the error. Or maybe they could do conversations during the surgery. You could say, I just gave 10 units of insulin, and say how you completed that task. Time, time is always a barrier too. More training, um, and yeah, like I already mentioned, cost effectiveness.